So I now am going to move on to introduce our first keynote speaker, Dr. Jonathan Tobin. So Dr. Tobin is a cardiovascular epidemiologist and implementation scientist whose research focuses on enhancing health equity and developing community academic research partnerships. Dr. Tobin specializes in designing and conducting comparative effectiveness research and dissemination and implementation research. His studies embed both basic science questions and implementation outcomes, and he employs a combination of big data, assessments of social determinants of health, clinical phenotypes, health services utilization, and laboratory measures. He builds full spectrum translational research teams that engage in laboratory investigators with practicing clinicians, patients, and other stakeholders. And so I'm very excited to hear Dr. Tobin as his work demonstrates this full spectrum of translational research from basic science to implementation. Dr. Tobin is president and CEO of the Clinical Directors Network, which is a primary care-based research network and an agency for healthcare research and quality designated center for excellence for practice-based research and training. He is also a senior epidemiologist, adjunct professor, and co-director for community-engaged research at the Rockefeller University Center for Clinical and Translational Science, and has held the rank of professor of epidemiology and population health at Albert Einstein College of Medicine. We welcome Dr. Tobin and look forward to hearing his remarks.
Thank you for the opportunity to talk about the work that I do with the Rockefeller University Center for Clinical and Translational Science and Clinical Directors Network. So this morning, what I'm hoping to do is share a model of community academic research collaboration that span the full spectrum of translational research from basic science to practicing clinicians and public health. I'll do this through reviewing 3 examples of community academic research partnerships that Rockefeller and Clinical Directors Network and our partners have built, and take a look at those projects and their results. And then finally, I will attempt to draw some conclusions about the strategies and structures that enhance the success and the sustainability of these partnerships. So that's my goal for this morning. And I will just begin with my disclosures, but none of these disclosures is relevant to this morning's presentation, although I'll be presenting some NIH and PCORI-funded research. So just to begin with some of the alphabet soup that I'll be sharing, practice-based research networks conduct comparative effectiveness research and patient-centered outcomes research. We draw very heavily on principles of community-engaged research and community-based participatory research, and in particular, the kinds of trials that we try to design are pragmatic trials, pragmatic clinical trials that combine questions of clinical effectiveness with questions of implementation. And so that's the framework that I'll be speaking about today. And this is probably very familiar to everybody in this audience, the translational research spectrum from pure and basic science all the way through to population level outcomes research. And so what I hope I'll be able to do is draw some principles from some of the work that we've done. So Rockefeller is unique in the sense that it is a basic science focused institution where heads of lab develop their own research agenda and collaborate with other internal and external partners. And we have an NIH-funded CTSA grant for our center that goes back to 2006. And a big part of that, which I've been involved with since the beginning, is the Community Engaged Research Corps that engages communities with basic scientists and tries to bring community representation, both practicing clinicians and more recently patients and other stakeholders early on into the design of research. And we try to conduct research across the lifespan. And just to begin with a further definition, practice-based research networks, as many of you are probably aware, are defined by the Agency for Healthcare Research and Quality as a group of ambulatory care practices with a network structure that transcends a single research project that strives to link practicing clinicians with experienced clinical investigators. And there's a very critical focus on workforce development in the sense of both enhancing the research skills of the network clinicians who participate in research, while at the same time using that same structure not only to generate new knowledge, but to disseminate and implement that knowledge. One of the, I think, most significant challenges in these types of collaboration is the often non-overlapping mission of research and practice. The practice-based research network primary goal of our members is the care of patients, in our case, primary care of patients, with the goal to improve access and quality of care. And the types of research often derive from questions that are relevant to the practice setting. And so Clinical Directors Network, CDN, the organization that I lead, is a primary care practice-based research network. And we really work in 4 different distinct but overlapping domains. Practice-based research is the primary activity, and within that, we use that structure to develop novel partnerships between primary care clinicians, specialty clinicians, academic researchers, health services researchers, laboratory investigators, public health, and other supporters. And a big part of the interactions between CDN and the primary care membership take place through education and training, most often through Zoom. But for many years, we've been doing hybrid training sessions, even pre-COVID, where we would take a curriculum on site to one of our member federally qualified health centers, but use a simultaneous Zoom link to be able to get the training and materials more widely. So Zoom has always been or its antecedents have been a very important dissemination strategy that really has served us well. And several years ago, CDN was selected by the Agency Healthcare for Research and Quality as a P30 Center of Excellence for Practice-Based Research and Learning. And this has really been a very critical opportunity to grow and develop a more national footprint through our partnership with 12 existing practice-based research networks, as well as with 3 of the PCORE network clinical data research networks, and more recently with several of the health information exchanges. And so these allow the interaction among these networks and among the partners of these networks to conduct research and training activities. If we look in the core area where CDN has been for the last almost 30 years, which is U.S. Public Health Service Region 2, I just want to give a sense of what the national image looks like for federally qualified health centers. There are almost 1,400 nonprofit grantees with over 17,000 delivery sites, 15,000 FTE physicians, and that group sees some 31 million patients, most of whom are low income, many of whom are minority, many of whom are medically underserved, except for their access to care. But if you look at what brings their patients into the health centers, these are the conditions, both nationally and locally, that drive a large part of clinical care with FQHCs, and they are cardiometabolic conditions, mental health issues, and other issues related to clinical preventive services. And so the patients that have been enrolled in our studies, and to date we're closing in on 400,000 patients that come from over 600 federally qualified health centers that have worked with CDN, are largely women and high percentages of African American and Latino patients. And so this is, I think, an important opportunity to reach patients who have not been part of clinical research and to engage clinicians and their care team in the research enterprise. And so just to drill down a little bit deeper, this is a PCORE-funded study with 2,000 randomized patients from 4 health systems, 2 in New York and 2 in Chicago. But just to drill down a little bit on the characteristics of the patients in New York, when we examined the entire range of adult patients in those two systems, as you can see, the metabolic, cardiovascular, and renal diseases are quite common. And also importantly, are comorbidity, and patients often present with multiple comorbidity. And so almost half of the patients have two or more chronic conditions, and that's going to be quite important for research and for the issue of adaptation. And if we look specifically at the 1,500 patients in this trial that have diabetes, 85% of them also have hypertension. These are patients with multiple chronic conditions that are being randomized to one of two interventions to reduce unplanned hospitalization, emergency department visits, and disability using a multi-component intervention. So these are the patients typically seen at federally qualified health centers, and these are exactly the patients who are often excluded from the clinical research enterprise. And as I mentioned, we use a lot of workforce development strategies such as online CME-accredited programs, and through our Center of Excellence, we had the opportunity to develop a certificate program in practice-based research methods with all of the other participating P30 grantees. That curriculum is still available on the CDN webcast library. More recently, we received funding from PCORI to develop a training that brought together practicing clinicians, their members of their healthcare team, and patients to learn together methods of patient-centered outcomes research. And these two curricula are available for free on the CDN website. And collectively, we've generated over 1,000 hours of CME and have had nearly 60,000 primarily clinicians from FQHCs, health departments, and from community-engaged research cores of CTSAs. And so I think this has been an important part of the engagement strategy that we've used to bring partners into the research enterprise. And similarly, working with patients, it's been very critical to use structures such as community advisory boards to designate patient ambassadors. And this is a snapshot from a workshop that we did at PCORI on this trial, where actually the presenters, we didn't present, we brought the patients to present and talk about their experience in practice-based research. So to try to talk about how we do this, we've tried to combine the structure of a practice-based research network, CDN, with the CTSA infrastructure. And the two entities have different but some overlapping strengths that have given us the opportunity through this model of bringing practicing clinicians together with laboratory investigators to conduct community-engaged research, comparative effectiveness research, and at the same time, as I'll show in a moment, embed both mechanistic studies at one side of the equation and implementation outcomes at the other side. So the first example that I'd like to mention briefly actually is not working with a community health center, with a federally qualified health center, but with a network of senior centers, now referred to as older adult centers in East Harlem in New York City. And when we began with our collaboration with the Carter Burden Network, which provides congregate meals to older adults, so they are directly intervening on several of the unmet social determinants of health needs, we learned both through questionnaires and examinations that there was a very high prevalence of hypertension, not surprising to everyone in this audience, many with poorly controlled hypertension. And we asked the question whether we could implement two evidence-based interventions, the dietary approach to stop hypertension, the DASH diet, and home blood pressure monitoring. So we had the opportunity, with some funding from the Administration for Community Living, to bring our research team into this novel set of community-based sites, to work with the food service staff to translate these complex principles of biochemistry and metabolism into food service delivery. And so this is a large team with many individuals at the service delivery sites, from CDN from Rockefeller, and a number of advisors from different nonprofit and New York City government agencies were part of the advisory team, which we think is going to be very critical to its implementation, scale up, and sustainability. So our goal was to enroll 200 older adults who were receiving their congregate meals at one of two of the older adult centers, and those participants, everybody for that matter, received the DASH diet in the meals that they took at the site, and they received a Bluetooth-enabled home blood pressure monitor, and we trained them, and our primary outcome was change in systolic blood pressure at 1 month. And we were also interested in seeing whether this improved the proportion of patients whose blood pressure was well controlled. So we took the diet and we worked with the food service staff. The bionutrition team from Rockefeller worked very closely with the food service managers, but we were also very concerned about patient or participant preference and choice. And so that played a key role in adaptation. So we had a high fidelity diet that was highly adapted to the local preferences and tastes of the people who take their congregate meals. This is a snapshot of one of the training sessions that our bionutritionists provided for the older adults, so that not only when they ate their meals at the center, but also when they shopped, when they ate at home, prepared their own meals, they would, we hope, use the DASH principles. And then we provided a home blood pressure monitor. We linked it to a website where we could download the data and upload it to a research database. And we encouraged the participants to record their data and into these diaries and share it with their clinicians. We were interrupted by COVID, so recruitment stopped at 100 with about almost 50 at each site. And as you can see, the average age was about 73, high percentage of low-income minority participants with a lot of stage 1, stage 2 hypertension, and a few individuals whose blood pressure really would have been considered in crisis. And to cut to the chase, at the end of 1 month and 3 months, we had significant reductions in blood pressure, overall about 4 millimeters of mercury. And at one site in particular, we were able to reduce by 8 millimeters of mercury. We also had increases, though, because of the small sample size, it failed to reach statistical significance, but we were able to increase the proportion of patients with controlled blood pressure. But at 6 months, when we had participants return with their home blood pressure monitors, we saw not only a significant increase, but a sustained and larger increase of almost 7 millimeters of mercury. So this is the kind of reduction you get by adding 1 or 2 additional medications to somebody with hypertension. And so this was really more than anything else, proof of concept that we could disseminate and implement evidence-based strategies with partners in the community using the same principles of implementation science. We looked at meal satisfaction both before and after we implemented the DASH diet and found no diminution in satisfaction. This is the best surrogate I could share of a patient-reported outcome, and this was evidence that we didn't increase food insecurity, which would have been an important adverse outcome. And using the REAIM framework, we reached about half of the eligible participants, reduced their blood pressure by 4 millimeters, were mercury, able to change the meals through health education, food delivery, serving DASH-compatible meals, and we were able to maintain the blood pressure reduction at about 7 months. However, we left our partners with about a 10% increase in food costs. But at the same time, I want to go back to that notion of full spectrum translational research. And in parallel with that study, we admitted 10 older adults with stage 1 hypertension, where you wouldn't necessarily treat with medication, but you'd use lifestyle. And we admitted them to the Rockefeller University Hospital for a 3-week period of intensive feeding and monitoring. And so not only at the end of that period of time could we ask and address the questions of implementation and effectiveness, but we learned a lot by collecting 24-hour urines, 24-hour ambulatory blood pressures, about changes in aldosterone and electrolytes that relate to or respond to the dietary intervention and reduce blood pressure. And we also examined renal exosomes to identify some novel proteins that were upregulated during that process. And so this was a way of bringing together a basic scientist with a practicing clinician. Practicing clinicians and practitioners in older adult centers. I want to share a second longer collaboration that we've had on disseminating and implementing the IDSA guidelines for MRSA. These were called the CAMP projects. And the clinical dilemma here is that clinicians in primary care often see skin and soft tissue infections that are recurrent, that are resistant to antibiotic treatment, that may not effectively go away. Our basic science collaborators are interested in the genetic variation and the associated genotypes of resistance, but the convergence between those two happens around antibiotic prescribing, resistance, reservoirs of infection, and clonality. And so it was in that combination that we were able to bring together a team of practicing clinicians from several FQHCs, in New York and in Chicago and in Texas, and bring together our laboratory team from Rockefeller University and initially collect observational data, which I'll mention. And I think what was contributing to the success of this implementation study was here's depicted a postdoc from Rockefeller who was interested in the molecular profiles, working with a PA and a pharmacist from one of our health centers in the Bronx. That group also spawned an investigation looking at the prevalence of MRSA versus MSSA among non-U.S. born as compared to U.S. born patients in FQHCs. This was led by a nurse practitioner from another one of our sites and demonstrated a significant difference that, in fact, the Latin American patients were much more often to have susceptible Staph aureus, which was the opposite of what we had predicted. Another nurse was interested in reaching out to a partner of her health center that it was a network of barbershops in East Harlem. And so we took our curriculum into the barbershops, talked about MRSA, also talked about hepatitis C, and we found that we could increase the knowledge from a baseline to 3-month follow-up by these equivalent of academic detailing, but conducted with staff in barbershops. And then the last part of the story that I want to quickly go through was stimulated by another clinician from our health center in the Bronx who at every one of our meetings, we would have a practicing clinician present a case study of soft tissue infection, treatment, and outcome. And we'd have a laboratory investigator talk about recent work that they did. And in one particular session, this physician talked about this particular patient that he was following who had a recurrent skin and soft tissue infection, seeing him several times. But he mentioned that this particular time that she was in to see him, she was rather upset because now her sister who was visiting also had developed the same infection. And so that led to a real interest in what kind of reservoirs are we not thinking about? And so that raised the question whether recurrence could be related to reservoirs that we haven't addressed, whether patients returning with recurrent infection, if we only treat the individual patient, are we failing to eradicate the reservoir? Laboratory investigators were interested in whether the recurrent phenotype reflected a single or multiple genotype. And we found about a third of the patients had recurrent staph infections. And so this led us to focus on the clinical correlates and laboratory correlates of infection recurrence and to prioritize an intervention to prevent infection recurrence. Around the same time, Susan Wang published her paper on the success of universal decolonization in ICUs, and we wondered whether that same logic could be applied and implemented in the home setting with promotores, community health workers. And we had seen another paper that had come out suggesting that there were probably unrecognized community reservoirs of Staph aureus. And so those two together led us to, again, our concept of a basic science and public health policy collaboration. And what was critical here was in the grant that PCORI funded for this intervention trial, we had aims that corresponded to each of the different spectra along the full spectrum of translational research. So we started with a comparative effectiveness research question of implementing by home visits from promotores this home-based intervention that was analogous to what Susan Wang and her colleagues had implemented in the ICU setting. We were interested in understanding patient level and environmental level factors and how they contribute and whether there were genotypic variations in response to decontamination, decolonization, recurrence, and household transmission. And this also gave us the opportunity to explore the evolution of stakeholder engagement over a longer period of time. So very briefly, we did surveillance cultures of the patients and the household members and environmental swabs at baseline in 3 months from these 11 high-touch surface areas. We found fairly high rates of colonization, both among the index patients and among their household members. So again, the idea being that there may be these important reservoirs. And similarly, more than half of the households had more than one contaminated surface, contaminated with either MRSA or MSSA. And so this gave us an opportunity over time to examine changes in the microbiome of the index patient, the household members, and the household environment in relationship to infection recurrence. And so you can see that decolonization, not surprisingly, using mupirocin and chlorhexidine was effective for both the household members, and we were able to increase the proportion of people who returned with no colonization at 3 months. In terms of household members, we also saw reductions, though they were not statistically significant, but we did see reductions in the reservoirs in the household that might have been related. Unfortunately, or fortunately, the rate of recurrence was so much lower in this population recruited for the trial as compared to our prior trial that we failed to show a significant effect on infection recurrence at 6 months follow-up. So we have lots of thoughts about whether the dose was inadequate, whether we would need to repeat the intervention over time, but we're still learning a lot about it, and we have a biorepository with thousands of specimens that we've been able now to share with a partner at the USDA who's identified a particular strain of MRSA that's associated with chicken exposure. And so there may be other reservoirs outside of the household that come into the household. And we're working with another partner at Weill Cornell who's doing whole genome sequencing and metagenomics, again, on this rich biorepository and clinical database that we've assembled from these patients. And so to summarize this part of the example, I want to acknowledge Dr. Alex Tomash, who was the head of lab of bacteriology, passed away last month, but worked with us from the very beginning and provided all of the laboratory investigation support and insight into how susceptible Staph aureus becomes resistant. But as you can see in the T3 shot, when we showed a picture to a barber, he was so familiar with wounds that look like that and was very concerned as to whether that could be transmitted to the other barbers, whether they would transmit it to other customers, take it home. So this is a reminder that implementation is not just in healthcare delivery, but it can be with senior centers, older adult centers, barbershops, other community-based providers of services that really have an important role in the larger healthcare ecosystem. And then finally, we recently began with funding from the Stavros Niarchos Foundation, a partnership to build research around Chagas disease using both big data and we hope in the near future, we'll be able to have biological specimens. But this began by assessing from the participants of this partnership, what are the research priorities and what are the clinical practice priorities? And this word cloud summarized the areas of interest that came from this national collaboration. But it broke down into 5 categories: education, detection and screening, prevention, treatment, surveillance, and congenital transmission. Those were the priorities where we had alignment and agreement. So we developed a 4-part CME program that reached over 400 participants. About a third were clinicians and half from health centers and health departments. And this is a relatively new, we're just starting the beginning of our 2nd year. But on the big data side, we've surveyed a number of different data resources and found something rather, I think, important here, that the CDC estimates that there's somewhere around 300,000 patients in the United States with Chagas disease, chronic infections. And yet, when we surveyed all of these different local and national resources, we found handfuls of patients, a few hundred in New York, that is a very large Latin American population. But we could only find just about 2,000 nationally between actually 3 different independent data sources. So there's a very large burden of undiagnosed and underreported patients with Chagas disease in the United States. And so we look forward to trying to use some of these same principles of collaboration to engage a wide range of partners in and outside of the healthcare setting, with laboratory investigators who are developing novel screening tests, novel treatments, and potentially repurposing existing effective interventions to prevent some of the very serious long-term adverse consequences of Chagas disease. So we have again used the same notion of bringing together a practice-based research network with a CTSA to try to conduct these studies that combine both embedded mechanistic studies and implementation outcomes. So to try to tie all of this, we try to use principles of design for dissemination. When we develop our collaborations, we look at dissemination through implementation tools and ask the clinicians and the staff, how are these results going to be helpful, and really try to make sure that we're designing studies that can answer questions that can be implemented in routine practice. We have, I think, been very successful at building this network of networks that provides a range of CME and support for conducting pragmatic trials that leverage the rich data in electronic health records. As messy as those data can be, we can extract a lot of useful information and build that into experimental and observational studies. But this really flips the idea of translating practice into research, and it helps us by thinking exactly as was mentioned at the beginning, how do you align research with operations in a way that produces better access and better results? And so we have had a large range of different partners, and we think that it's critical to bring all of those partners to the table to ensure that we're asking questions that are of importance to each of them and providing insights into the implementation strategies through research, where the research really serves as a test bed to refine those principles of implementation science in practice-based settings, where we learn a lot about the interaction between context and adaptation. And we try to combine research rigor with the flexibility and adaptation of implementation strategies. And so the model that I think works best for this is taking the concept of hybrid effectiveness and implementation studies that are designed with pragmatic principles, can be embedded into practice-based settings. It's critical that they follow the workflow in the existing workforce, but that we bring external practice facilitators who work closely with the internal practice champions. And through this, we're able to leverage the real-world data that they collect as part of their electronic health records and other information sources that we can then combine with patient-reported data that may be beyond routine care, but still allow us to embed through a variety of different strategies, sometimes face-to-face, and certainly since COVID, we've experimented with many different remote technologies, text messaging, interactive voice response, and other approaches to try to minimize the burden on the practice and on the patient. Finally, we're able to leverage trust by proxy, where our researchers work with trusted community partners who provide either primary care or other social services to patients in need, such as food and nutrition programs that serve food insecure patients, and really work closely to answer questions that enhance their delivery of services while understanding some of the broader principles. And so what we try to do, again, is combine that rigor, but with a high level of adaptation, and understand the relationship between context and the adaptation in order to try to use those to develop more generalized strategies. So I'd like to thank the conference organizers for this opportunity to share our work, and I'm eager to hear if there are questions or comments, and really looking forward to the rest of today's presentations.
Thank you so much, Dr. Tobin. I mean, that you presented so much valuable information that it's difficult to hone down to the few questions that we're going to have time to talk to you about. I do want to remind the audience to please put any questions into the Q&A, but I'll start by saying your work is incredible, and we're just so impressed with your ability to demonstrate to us this full spectrum translational work that you are involved with. I mean, when I think about everything you said, the two pearls for everyone to remember, this idea of designing for dissemination and translating practice into research. I think about that just at either side when you're a basic scientist or a clinical researcher, thinking about what are your goals? How are you going to ensure that the outcomes that you're collecting are going to be translatable to different settings, and what will you want to know about these different settings? And then the translating practice into research when you're on the other end, what are the issues that we're having with this translation? How can we create a rigorous evaluation program to help us do this better? A question I have for you, with all of your experience in partnering with health centers, senior centers, with patients, and going within their homes with the aid of community health workers, could you give us some pearls on maybe some differences that you've noticed with these different types of collaborations, and what you may need to adjust as a researcher who maybe doesn't have as much experience with these types of partnerships? How are they different? We'd just love to have your insights on that.
So I'll start with the similarities. When we work in practice-based settings, we're working with organizations and staff that, by and large, are passionate about what they do and very committed to delivering the best services that they can, often with limited resources. And so research falls outside of that scope, and therefore, the challenge in building these partnerships is finding the sweet spot where research answers a question of importance. And so when we began our partnership with the older adult centers in New York, they came to us and said, how do we prove, this is their language, how do we prove that our services improve the health of our clients? That was the question. Now, of course, that's a great question, and it's unanswerable, but we could begin to break it down into which services could potentially improve which health outcomes. And as we we did town halls and focus groups, we learned about concerns about high blood pressure, concerns about high cholesterol, about obesity, about diabetes, about mental health. And so it was an evolution of how do we find questions that are testable hypotheses, interventions that can be implemented and adapted in that setting, and outcomes that matter both to a funder, and at the same time to be able to implement a sustainable set of multi-component interventions that would be beneficial. And so the big part of that challenge, and it was the same with skin and soft tissue and the same with Chagas and with everything else, is finding those areas where there's mutual curiosity that can drive improvement in service and at the same time be beneficial to the careers of the investigators. They're not going to contribute their time and effort if it doesn't help them. They may want to be helpful. So there's a lot of time that has to be invested in building those relationships to find those areas. So I tried to illustrate that with the slide of the specific aims from the PCORI-funded home visit study, where we spent a lot of time really trying to drive to the surface what matters to each of the stakeholders and how can we translate those into testable or observable differences and hypotheses that could be studied in a rigorous fashion and not at the same time not interfere with the delivery of services. So I think that rigor, flexibility, alignment, and sensitivity to the fact that the academics have one set of priorities and the community has different sets of priorities, but there's opportunity to find overlap, and that's where the synergy works.
Great. Well, thank you. That was a wonderful presentation. Just so impressed with the T1 to T5 progress that you've made and the impressive outcomes for our patients. And I'm delighted to be here with Dr. Misra Hebert, and I'm Mary Dolansky, and I also am very intrigued with how you collaborated or got your teams to work together, particularly your scientists. So I teach team science to our CTSC members and community, and it's always hard to get the scientists to be thinking about maybe discovery together or even sitting together. So I was just curious what kind of practical strategies you've used to get your scientists to engage in team science.
It's a great question, and it's a work in progress. And it usually started with the conversation where the scientist would say to me, and I'm paraphrasing, but it always took the form of, can't you just send me the specimens? And frankly, I understand that. That's what they do best. But the answer inevitably was, I could, but I can't and I won't. Because if we're going to build this partnership, we have to learn from each other. And if we just send you specimens, they're disembodied, they're decontextualized, and it loses the richness of having those conversations that put the context back into what are the lives that people are living that are generating the conditions that produce that pathology, those specimens. And so I think the basic scientists who have gone through it, and there aren't a lot of them, and it's a very time-consuming, labor-intensive, and long latency process because you, as we all know, if we had a great idea and began to work on a grant today, best case scenario at NIH or PCORI, it wouldn't start for a year and a half, and likely it would start for 2.5 years. And then back to our partners, it's not going to produce results until 5 years into it. It's not going to get published till a year later. So we're saying today the concept that we're starting with for a great study isn't going to be answered for 8 years. That's a long time to wait. So the other critical strategy for both sides of the equation is to find short-term interim effects that can be valuable to the practice-based settings and to the laboratory investigators. So generating some of those specimens was the currency for the laboratory investigators, generating CME data systems. So in our Chagas project, we have a lot of sites that are interested in maybe collecting data, but not able to analyze it. So we've built a research database and are helping them to extract data from their electronic health records. We have the bioinformatics and biostatistical support that they don't have. So finding that currency, CME is another one that's been really important. Those are the practical strategies in the short term of providing benefit to all of the partners.
Thank you. I really can see you're a great leader who is impacting a culture. So thank you for that comment.
Trying to. Thank you.
So, Dr. Tobin, I think we have time for one more question, and you have talked about adaptations and highlighted that word several times during your talk, and I just wonder, for the purists who are looking at the implementation outcomes and feel that that adaptations might change the rigor of the work that they're doing, could you just give us your comments on kind of strategies you've used to incorporate adaptations and maintain the core intervention that you're implementing?
So it goes back to the primary question of implementation fidelity. And so we have to start with what's the fidelity that we need to assess, and how amenable to variability is that fidelity. And so while I think prior to the advent of more people who think about implementation science, the study sections and peer reviewers would challenge studies that had some form of adaptation built in. So it is a continuum from pure fidelity, 100% fidelity, to the extreme end of the other side, which would be 100% do it your own way, a chaotic, non-uniform way. I think the way that Brian Mittman characterizes form versus function is a really critical way to think about this. And so if we have an implementation program, we have a product that we choose to implement, what I've learned working with FQHCs is every FQHC has different names of the roles of their staff members. And early on, I learned if I came in with an intervention and said, we need a psychiatrist or a licensed psychologist to deliver this mental health intervention, they tend to be rather rare in FQHC settings. They're not non-existent, but there aren't many of them. But we found many other individuals, some who were licensed health professionals, some who were allied health professionals, who have the training and the requisite skills to implement a manualized program. So we would take the program with the high level of fidelity that we would expect in a rigorous explanatory trial, and then look to see what are the functions that can be provided in a wider range of settings through a wider range of personnel. That's where the effectiveness, the hybrid effectiveness implementation design is so important, because we still need to show that it produces the clinical effectiveness that it did under the more severe laboratory conditions of an explanatory trial. So I think adaptation is a range of concepts that have to do with understanding the workflow in the settings and the workforce. Many, many years ago, I was involved in a study that was interested in headache guidelines, and this was done in an academic setting, so imaging was part of the workup. That's simply not the case in primary care in low-resource communities with uninsured or many Medicaid-insured patients. So that's just a trivial example of how adaptation becomes so critical to find other ways to get to the same answer. Who's at high risk of an adverse outcome? Who can be managed conservatively and through observation? So the outcome, it really drives the degree to which you can adapt the intervention. I hope so it gives you some insight into the approaches that we take.
Thank you so much. We really appreciate your being with us this morning, and we have some questions that appeared in the Q&A that we can probably send to you later, just in the interest of time. But thank you so much for starting off our seminar with your wonderful comments. And
thank you, Dr. Tobin. Thank you.